welcome back to you to this teleconferencing session. We shall continue from the previous session in this session also. But first of all, I must thank my regional directors who have sent the 2 faxes, and I am happy that the students and the counselors are watching this demonstration and the session on neonatal resuscitation. Since we were discussing about the chest compressions, I would request Dr. Mathur to start the chest compression, and then straightway we will go on demonstration. Kindly stay with us and also ask questions. I request the program in charges and the academic counselors, if they do not understand English, we can have the demonstration in Hindi also and send the questions to the experts. They are the national trainers of the National Neonatology Forum, and they are having so many sessions on neonatal resuscitation. So kindly send the questions, whatever queries and questions you have on neonatal resuscitations, please send us. So Dr. Mathur, please start on chest compression.
As I said earlier, the baby after birth receives initial steps for 30 seconds, at the end of which there is an evaluation. After evaluation, if there is an indication, which means the baby is apneic, or he is gasping, or his heart rate is less than 100 per minute, then there is indication for bag and mask ventilation. If he is centrally cyanosed and does not respond to oxygen for 30 seconds, then there is an indication for bag and mask ventilation. Once there is an indication for bag and mask ventilation, the bag and mask ventilation is given for a period of 30 seconds. At the end of 30 seconds, there is an evaluation. So you evaluate the heart rate. If the heart rate is less than 60 per minute, which means less than 6 heartbeats over a period of 6 seconds, then there is an indication for chest compression. Now let us first understand what is the site for giving chest compression. So the site for giving chest compression is below a line joining the 2 nipples of the baby, in the lower third of the body of sternum or the chest bone. So over the body of the chest bone, just below a line joining the 2 nipples, that is the site where chest compression is given. Now chest compression can be given by 2 techniques. One is by using the 2 fingers and compressing the chest downwards up to 1/3 of the chest. So the chest is compressed by 1/3. So this is one method. The other method is also called the 2 thumb technique, in which the baby's chest is encircled. The 2 thumbs are placed vertically over the chest bone, and there is a flexion of 90 degrees in the thumb. So in the thumb joint there is a flexion of 90 degrees, and vertically the chest bone is compressed to 1/3. So this is the other alternative method. The two hands fingers are meeting at the back. So this is the method by which, by 2 finger technique, the chest compressions are given. So this is the thumb technique, and this is the 2 finger technique. So these are the 2 methods by which the baby has to be placed on the firm surface, and the chest compressions have to be provided. This is done at a rate of 90 per minute, and it is done in coordination with bag and mask ventilation, because the bag and mask ventilation has to continue simultaneously while the chest compressions are being given. And as I said, you would require 2 persons. Now how the bag and mask ventilation and chest compressions are to be coordinated is very important. So the person who is providing the chest compression says 1 and 2 and 3 and breathe. So when he says 1, he is compressing the chest. When he says end, the chest is released. When he says 2, the chest is compressed. When he says end, the chest is released. When he says 3, the chest is compressed. And when he says end, the chest is released. When he says breath, then the breath is given through bag and mask ventilation. And then again this procedure is repeated, which means that we have 4 events, 3 chest compressions and 1 bag and mask ventilation. So the bag and mask ventilation and chest compression are done in a ratio of 1:3, or 3 chest compressions to 1 bag and mask ventilation. Now the total number of chest compressions over a period of 1 minute would be 90 chest compressions, and the total number of breaths that would be delivered through bag and mask ventilation would be 30, which means over a period of 1 minute there would be 90 plus 30 events, which means 120 events over a period of 1 minute, which means that one cycle of the events of 3 chest compression and 1 breath has to be completed in a period of 2 seconds. So that is what is chest compression. This chest compression along with bag and mask ventilation would continue for a period of 30 seconds. At the end of 30 seconds, again there has to be a evaluation of the baby. In this evaluation, again we are going to see the heart rate by either palpating at the base of the umbilical cord or by auscultating the heart rate. If the heart rate is more than 60 per minute, then chest compressions can be discontinued. If the heart rate is less than 60 per minute, then the doctors would have to provide medications to the baby. If the heart rate is above 60 but less than 100, bag and mask ventilation would continue. If the heart rate is more than 100, then the bag and mask ventilation would discontinue. So this is providing the chest compression to the baby in neonatal resuscitation.
Dr. Mathur, how the health workers, suppose they get a situation that they need to give chest compression, so how do they identify the depth of the compressions? You said 1/3 of should be the depth. So how do they identify? What points they can keep in mind that while they are doing chest compression? How do they identify?
To provide effective chest compression, the heart has to be squeezed so that it is compressed against the backbone of the baby, and for that 1/3 of the chest has to be compressed. So I will show you how much is the optimum chest compression so that you can make out that this is 1/3 of chest compression. This has to be something like 2 to 2.5 centimeters, but ideally it should be 1/3 of the chest that should be compressed. So you can see how much is the chest anteroposterior diameter of the baby, and 1/3 of that has to be compressed. So that would be appropriate and sufficient chest compression.
And they also have to take care of the surface where they are conducting the resuscitation.
Yes, it is very important that the surface on which resuscitation is done should be a firm surface, because if it is a soft surface, a couch, or if it is being done on a bed which is soft, then it is better to follow the method wherein you are compressing with the thumb and your fingers are meeting at the back to provide the support. In case you are following a 2-finger technique, then with the other hand it is better to support the back so that there is a chest compression supported at the back by the other hand. So if the surface should be preferably firm. If the surface is not firm and it is soft, then when you are using the 2-finger technique, you have to be careful that you place the other hand at the back so that you are supporting the spinal vertebral column in the midline, and the chest compression is being done between your other hand and between the two fingers.
The other point which comes in my mind is that earlier it was advised that if the health workers do not have any equipments whenever they are conducting the deliveries in the home situation, and they don't have any resuscitation kit or anything, and then they used to give mouth-to-mouth breathing. So can the health workers nowadays also practice mouth-to-mouth breathing in situations where they don't have the equipments, or it is contraindicated now?
If the bag is not available, then mouth-to-mouth breathing can be provided, but it is important to understand that when you are providing mouth-to-mouth breathing, one is you have to be skilled in mouth-to-mouth breathing. In mouth-to-mouth breathing, you don't fill your lungs with air and you don't put the entire air in the lung into the baby, but rather you give mouthfuls of air to the baby. So your mouth should be filled with air like this. So you fill the mouth with air. This is the way mouth to mouth respiration has to be given. You don't fill your lung and give the entire breath to the baby, because that would generate a lot of pressure and it can cause injury to the lungs. However, it is preferable to have a bag available, because these bags are now widely available and they are even available, they are being made available even at the level of primary health centers and sub-centers. So it's preferable to be familiar with the use of a bag and provide bag and mask ventilation, because it is said that in resuscitation, giving a breath to the lungs or providing breath through the bag is very important. It is most crucial and it is most helpful in resuscitating a baby.
If suppose a situation comes and they have to give mouth-to-mouth breathing, so what precautions should they follow at that time? One, you said that they don't have to breathe
Yes.
vigorously into the baby's lungs, but what else they have? Do they have to cover
Yes.
the mouth
Yeah.
or whatever they have?
Yes. So the precaution is, number one is that it should be mouthful of air, and number two, a linen can be placed over the oral cavity of the baby and the breaths can be given through that. This linen should be a fine layer of linen through which the air would pass. A cotton linen can be placed over the mouth of the baby, mouth and nose. The nose has to be pinched and the breath has to be given through the mouth. So basically there are three precautions. One is give mouthful. Second is you pinch the nose. You place a linen, which is a cotton linen, over the mouth of the baby, and then you give a breath. So if you want to actually see how it is done, this is the way. You would apply your mouth over the mouth of the baby, pinch the nose and deliver mouthful of air to the baby.
Okay. Suppose Dr. Saluja, when a health worker is conducting a delivery and she finds that the amniotic fluid is meconium stained, and what steps she should follow at that time, what she should do, because she may not be skilled enough to tackle that situation. So what advice you will give to the health worker at that time? And you can just briefly say what exactly they should do, because maybe the child may need endotracheal intubation or tracheal suctioning. So how can you advise them what they should do during this situation?
See, when the baby is being born through meconium stained amniotic fluid, the initial steps have to be the same. You see, if you remember the 4 questions we asked, if the liquor is not clear of meconium, that means this baby goes for initial steps. And the first part of initial step is we place the baby under a heat source or a warmer. Then we position the baby in the standard position of resuscitation, which was told to you, in neck slightly extended. So the neck is slightly extended and not hyperextended, neither flexed. Then you have to decide whether this baby is vigorous or not vigorous. A vigorous baby is one who has strong breathing efforts, who has a good muscle tone. Muscle tone means his limbs are flexed, and whose heart rate is more than 100. So these three criteria are required to classify whether this baby who is born through meconium stained amniotic fluid is vigorous or not vigorous. If the baby is vigorous, which means the heart rate is more than 100, baby has strong respiratory efforts and has a good muscle tone, then you have to proceed with the rest of the initial steps, means you have to clear the oral airway. You should use a suction catheter which is at least 12 or 14 French gauge. All of you know that suction catheter come in different sizes. Now when routine suctioning is done, then 10 French catheter is good enough. But if a baby is being born through meconium stained amniotic fluid, then you need a suction catheter which is at least 12 or 14 French catheter. And then you have to suction the mouth of the baby, mouth first and then the nose. You have to remember that if you do the suction of the nose first, then whatever meconium is lying in the mouth, baby can inhale into the lungs. And if you remember your ABCD, your alphabets, the M comes before N. So you should suction the mouth first, followed by nose. But if the baby is not vigorous, that means baby does not have a good respiratory effort, baby is limp, muscle tone is not good, or if the heart rate is less than 100, then you have to do endotracheal suctioning of this baby, for which you need an equipment. This is the laryngoscope, which has a blade. The handle, make sure before you receive the baby that the equipment is working. You attach the laryngoscope blade, and you can see the bulb. I don't know whether you can see this light on or not. So this laryngoscope has two sides of blades. This is a small blade which is size 0, and this is a bigger blade which is size 1, which is used for bigger babies. You hold the laryngoscope in your left hand, put the laryngoscope into the baby's mouth, and then use an endotracheal tube like this, put it into the trachea of this baby and attach an adapter here which will be connected to the suction machine and which has a side hole. Block that adapter and take this tube out and see if there is any meconium or not. If the meconium is coming into the tube, then you perform endotracheal suctioning 2 or 3 times till the time you have cleared the trachea of meconium. But at the same time, somebody should be monitoring the heart rate of this baby. If the heart rate of this baby is falling, then you should abandon endotracheal suctioning and proceed further with resuscitation.
But I think the students which are present there, normally this procedure is not done by any nursing professional or any health worker. This is done by the expert doctor who is a pediatrician or a neonatologist or who has got training in neonatal resuscitation. But what you as a health worker have to do, that you have to inform immediately whenever you find such a situation. You have to inform immediately to the higher authorities, so that the doctor or whosoever is attending the senior person is attending the delivery, and you can then assist. But this is just for your information, that in certain cases whenever meconium aspiration is there, the meconium liquor is there, then the endotracheal sectioning and endotracheal intubation is being done, and that is being done by the expert, not by a nursing professional. So you only have to assist. We just since they don't have to do anything with the medication, but I would request you to just say the drugs which are commonly used, even if all these resuscitation measures fail and we have to resort to the drugs. So what are the different types of the medications which are being given to these babies, and what precautions need to be made in such situations?
I will only recommend one drug for them for neonatal resuscitation, and that is epinephrine or adrenaline. You would know that adrenaline comes in a strength in India which is 1 in 1000. We have to dilute this epinephrine into 1 in 10,000. How can we do that? If you were to take 1 ml of epinephrine and dilute that with 9 ml of normal saline, which makes it 10 ml solution with a strength of 1 in 10,000. The dose for giving epinephrine is 0.1 to 0.3 ml of this 1 in 10,000 solution. That means this diluted solution, which preferably should be given through intravenous route by doing an umbilical venous catheterization. The umbilical vessels are here. We can place an umbilical catheter through that. But in emergency, if umbilical venous or vascular access is not available, the same medication can be given through the endotracheal tube, which is in place, but the dose of giving medicine epinephrine through the endotracheal tube is little higher, which is 0.3 to 1 ml per kg. If we were to estimate that the baby's weight is 3 kilos, that means we will give something like 1 ml of epinephrine through this and roughly 0.3 ml of epinephrine through the vascular route. That's the only medication I would like to say.
I would request the program in charge sitting at the regional centers to send any questions at Sadbarwa and Dehradun. I would request you to send your questions. If you have any queries regarding neonatal resuscitation, kindly send your questions. Yes? I hope you are watching the teleconferencing. Okay, as the whole process of neonatal resuscitation has been covered by the two experts here, we normally know that as has been discussed in the early session, that the 80 to 90% of the babies will not need any neonatal resuscitation. Only they may need evaluation and checking of Apgar scores and assessment and all that, because normally the babies will breathe spontaneously at birth, as has already been discussed. But during the handling of the baby, covering, wiping, cleaning and all that, the baby also gets stimulated. But if it doesn't happen, if during the routines it doesn't happen, the baby is not able to breathe within 30 seconds of that after the birth, then we have to institute the resuscitation steps. For the health workers, it's very important to learn the initial steps of resuscitation, because they have already shown you the algorithm, that is the flow chart of resuscitation. You have to ask 5 questions, as had already been said by Dr. Saluja. If the answer to those 5 initial questions is yes, then you have to give routine care, that you have to clean, cover and then wipe and dry and then keep the baby skin to skin with the mother. But if the baby is if the answer to any of these questions is no, then you have to follow the steps of initial steps. And these initial steps are very important, because if these initial steps are done correctly, then you may not need to go further to the bag and mask, chest compression and further any other resuscitation. And therefore you must be able to develop the skill of initial steps properly. So I would request you, sir, to just start the initial steps from the delivery of the baby, and then show the exact procedure in a systematic way, so that they will be able to follow the initial steps when they are doing conducting the delivery in the home situation. So we must keep all whatever the sheets have to be kept. What initially we may start with the preparations. Suppose they are attending a delivery and then they have to receive a baby. And then what are the preparations for resuscitation which they have to make? So what all important points should the health workers keep in mind when they are foreseeing that the baby has to be resuscitated?
For initial steps, we would require 2 dry sheets. So we have one sheet here and we have another sheet here. These should be pre-warmed and dried. Then we require a radiant warmer bed. So we presume that this is the radiant warmer bed. Then we would require a device for suctioning. So like this is a Deeley strap for suctioning of mouth and nose. So this would be required. So now, when this baby is delivered, then the first step is warmth, which means the first step is we would place this baby in a sheet under the radiant warmer. Then the first step would be to position the head. So the positioning of the head should be in a sniffing position, which is slight extension of the head. If it is flexed too much, then also it is not correct, or if it is hyperextended, then also the airway is not properly aligned. So it is a slight extension of the neck. Then after that, we can place, to maintain this position, we can place a roll of a cloth which is around 1 to 1.5 inch below the shoulder, so that this position is maintained. Then subsequent to that, suctioning is required. So we would first suction the mouth, and then the nose. So we first suction the mouth and then we suction the nose. Then we dry the baby and then we remove the wet sheet and then wrap the baby in a dry sheet. We reposition the head and provide physical stimulation. So this physical stimulation is if the baby is not breathing, then we will have to give physical stimulation. This physical stimulation is in the form of flicking the sole twice. So this is flicking the sole twice, or as an alternative, we could rub the back. By rubbing the back, we can provide physical stimulation. So I would again repeat the initial steps. This baby who is being delivered just now is placed under the radiant warmer. His neck is positioned. We place the shoulder roll to maintain the position. I suction the mouth and then the nostrils. I wipe the baby dry. I change the sheet and again wrap the baby in another dry and pre-warmed sheet. If the baby is still not breathing, I provide physical stimulus to the baby only twice. So this would be the initial step. If the baby is cyanosed, if he has central cyanosis, then in that case I would start with administration of oxygen. So these are the initial steps to resuscitate the baby.
Dr. Mathur, what are the different ways of giving free flow oxygen and how it should be given?
To provide free flow oxygen to the baby, you can use an oxygen catheter through the oxygen source. You can have oxygen catheter. This oxygen catheter, you can place it between your fingers so that a cup is formed, and you can place this over the mouth and nose of the baby. As an alternative, you can attach it to a face mask, and that can be kept not very tightly opposed to the face of the baby, and that can also be provided. So you need an oxygen source and oxygen catheter, and then it should be placed in front of the nose of the baby, and you can cup your hand around this catheter so that free flow oxygen can be provided to the baby.
So what should be the flow rate of oxygen when you are giving free flow oxygen?
The flow rate of the oxygen should be between say around 5 to 6 liters per minute, so that oxygen should be flowing and the oxygen can be provided to the baby.
But can you use this mask to give free flow oxygen?
It is not appropriate to give free flow oxygen through this self-inflating mask, because when you are giving oxygen through this self-inflating mask, then the pressures developed would not be sufficient to open all the valves and give oxygen to the baby.
So after you have given free flow oxygen to the baby for 30 seconds, what do you do next?
Now after the initial steps, provision of initial steps for 30 seconds, if the baby, we evaluate the baby, so we see for respiration. If there is no spontaneous respiration, then we have to give bag and mask ventilation. Or if there is spontaneous respiration, but we palpate the base of the umbilical cord, and if the heart rate is less than 100, then also there is an indication for bag and mask ventilation. Again, if the heart rate is also more than 100 and the baby is having spontaneous breathing, but he is centrally cyanosed, we give him oxygen for 30 seconds. If he still remains cyanosed, then also it is an indication for bag and mask ventilation.
So that means our equipment for bag and mask should be ready, and if we have oxygen, we connect this oxygen source to the oxygen inlet, and if we have a reservoir, we connect the reservoir to the ambu bag. But if you do not have oxygen, still you can give positive pressure ventilation with the help of this device, which is the resuscitation bag with attached mask. This is a round cushion mask. It has cushions here, if you can feel, and this is a soft mask which does not damage the soft tissue of the baby's face. So what have we learned? If after 30 seconds of initial steps, baby is not breathing or gasping, if the heart rate is less than 100, or even after this, if a baby is breathing and the heart rate is more than 100, and after giving 30 seconds of free flow oxygen, baby still has central cyanosis, then we should give bag and mask ventilation. This mask should cover the tip of the chin, the mouth and the nose, and not the eyes. The eyes should not be covered. We place this mask in such a way that the chin, mouth and the nose is covered. Make sure that the baby still has slightly extended neck, because if the position has been altered, then your bag and mask is not going to be effective. So you place this, let the shoulder roll be there beneath the chest, and then make a tight seal over the baby's face, and then give positive pressure breaths. And you can see every time I give a breath, the chest is rising. And what should be the sequence of giving breath? I should say breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3. You see, with every compression of the bag, you can see the chest rising, and the chest rise should be just enough and not a very large degree of chest rise, because if it is hugely rising above the baseline level, then you are giving very excessive pressures. Now what do I do after this? After I have given positive pressure ventilation for 30 seconds, then I again evaluate the baby. I palpate the umbilical vessels and count the heart rate. If the heart rate is more than 100, then I assess the color of the baby. But if the heart rate is less than 100, what do? I continue my positive pressure ventilation for another 30 seconds. But if after 30 seconds of positive pressure ventilation, the heart rate is less than 60, what do? I call my partner and we start a coordinated chest compressions along with positive pressure ventilation. Now we will show how to give coordinated chest compressions with positive pressure ventilation. The person who is doing chest compressions now should count as we were counting at bag and mask ventilation. Yes.
1 and 2 and 3
and
breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
So this way he gives 90 chest compressions and I give 30 positive pressure breaths in 1 minute. What do we do after that? After 30 seconds of this coordinated chest compressions and positive pressure ventilation, we again count the heart rate. We need somebody else to count the heart rate for us, or the person who stops chest compressions counts the heart rate. If the heart rate is less than 60 still, we go to the next step, which is giving medications. But if after 30 seconds the heart rate is more than 60, what do? He stops chest compressions, but I continue to do positive pressure ventilation till the time baby's heart rate goes above 100 and the baby starts breathing spontaneously and the color improves. So the efficacy of positive pressure ventilation is that the heart rate should rise above 100, baby's color should improve, baby's tone should improve, and the baby should be breathing spontaneously.
So one of the important areas of focus is that when you are going to conduct resuscitation, the baby has to be provided warmth. And what should be the temperature of the room at that time that the resuscitation is to be?
Dr. Pitti, before I answer that question, I think I would like to emphasize on one more thing. You see, right in the beginning we said that at the time of birth we have to ask 4 questions to ourselves. 1, is the baby being born at term? Is it full term? Is the liquor clear of meconium? Is the baby crying or breathing? Is the muscle tone good? And if answers to all these questions is yes, that means it is a healthy baby. Then this baby gets routine care. Let us say that this is a healthy baby where answers to all those questions was yes, I received this baby. Now there is no need for this baby to go under the warmer. The routine care which this baby needs can be provided on the mother's abdomen and chest. We take this baby, place it prone over the mother's abdomen, turn the head to one side. If there are secretions, clear the secretions by just wiping it out, and then we dry the baby, the scalp, the neck, the axilla, the arms, back, the other arm, other axilla, legs, the groins. We slightly turn the baby, dry the anterior part of the baby. We dry the mother's abdomen also because that has also become wet, and we throw away this wet sheet. After we have thrown that wet sheet, we cover this baby over the mother's abdomen, cover the scalp. Now this baby is ready for breastfeeding and we should initiate breastfeeding. So this is the concept of routine care which should be provided to all healthy babies, where answers to all those 4 questions which we asked was yes. So the routine care does not need any equipment, does not need a warmer. Mother's abdomen and chest and baby in skin to skin contact acts as a source of warmth. Then there was a question that what should we do, what should be the room temperature? I don't know what's the situation in the community at the ground level where air conditioning are not there. So rooms are usually not very cold, but in the months of winter the rooms may be very cold. The temperature of the labor room or the area where delivery is being conducted at house or in the community should be something like 28 to 30 degrees. If they have a room thermometer, they can monitor that. It should be comfortable enough for the baby and not for the mother or the birth attendants who are going to witness that delivery.
The situation where the adult can feel uncomfortable.
Yeah.
That is the ideal temperature for the
It should
baby.
be little uncomfortable for the adults. That is the temperature which is comfortable for the newborn baby. And we know the newborn baby is coming out from a wet environment. Baby is wet at the time of birth. So giving a source of heat and drying the baby with a pre-warmed clean sheet. It should be warm. It is not that sheet should be cold. So we should have 2 or 3 sheets which are warm sheets which should be readily available to dry the baby and wrapping the baby again with a dry sheet.
So what preparations they should advise the mother who is going to get delivery in the home situation or in the health center?
So in the home they should have a room which is clean, which is warm, which is free of draught. Very often if it is windy, beneath the doors they will have a draught of air which can make the room cold. They should have some heat source. You can have 200-watt bulbs, or you can have some heating device. Avoid having an angithi in the room because that may have smoke which may be injurious to the baby. So it should be neat and clean room. They should have a clean space designated for delivery where they should have a soft padding and a sheet where the mother is going to lie, and then they should have a set of 2, 3, 4 pre-warmed clean, washed and sun-dried sheets, which could be warmed even on the angiti or anywhere else. So it should be warm and not very hot. So this is the only, and they should observe the 5 cleans of delivery which we talk about.
They need to have, do they need to have resuscitation corner in their rooms where they
You see, in
are
the
going to
home
conduct?
you cannot have a resuscitation corner. You can just have a place with a heat source. That will in fact be a resuscitation corner without any resuscitation equipment. But surely if a delivery is being conducted in a health facility, all areas where deliveries are being conducted should have a designated newborn corner. And for example, in primary health centers now, many of them have radiant warmers. So they should have a newborn corner where there is a radiant warmer, where there is other equipment available.
And they must also remember that when the baby is under the radiant warmer or the heat source, we do need to cover at that time if the resuscitation is going on, because they have to make observations of the rise and fall of the chest and heart rate and this thing.
You see, if you have a servo-controlled radiant warmer, once you have dried the baby, then you can throw away the wet sheets and then let the baby be naked under the source of heat till the time baby needs observation. But once the baby is stabilized, wrap the baby in pre-warm sheets and give it to the mother. Or if you want to shift to the nursery, then you can shift the baby to the nursery.
Dr. Saluja, there is one thing, there were different types of catheters are being used when the suctioning or endotracheal intubation is being done. Different type of catheters are used and different types of masks are used. Can you tell us in which situations the types of catheters? Can you give us a just quick look?
It's simple. The suction catheter for mouth and nose suctioning is 10 French catheter. For those babies who are born through meconium stained amniotic fluid, use 12 and 14 French catheter. That's the only 2 catheters. Masks, I think I have discussed quite in detail that you have different sizes of masks, so that has already been covered.
Dr. Mathur would like to add something regarding resuscitation or?
In resuscitation, to summarize, the philosophy is, number 1, one has to be prepared. Number 2, the actions have to be prompt. And number 3, adequate trained or skilled persons have to be available to provide resuscitation.
Okay. I thank you for giving a nice demonstration and presentation on neonatal resuscitation. Thank you, Professor Mathur, for your detailed discussion on initial steps and chest compression. I also thank Dr. Saluja, who has given a very skilled demonstration on resuscitation. I hope this presentation must have helped a lot to the health workers and the teachers who are along with the students right now, and they will practice these steps, and even if they have any queries, they can send us through fax, or they can also inform me on phone so that we can clarify. I hope this presentation must have helped you to understand the skills of resuscitation, and then since this is one of the activity in your training program, so in your subsequent sessions you will be teaching the neonatal resuscitation to your students right at your own program study center. With this, I would also like to thank all the regional centers and the regional directors who have supported the students and the teachers to come and attend and made the arrangements for attending this session. Thank you very much.